How's it going, guys? So this question is very high yield for family medicine. I made it a very short stem here, cutting to the fucking point, okay? Very clean, easy question here, but you need to know this. So before we get started, please subscribe to my channel. I really appreciate it. And give the video a like. I really appreciate it. And find me on Instagram at Mehlman_medical, MEHL_medical. Link is down below. And find me on Telegram. Links are down below. Now, starting this actual question here, where we have a 38-year-old dude with high blood pressure, 150 on 90 on 2 previous visits. Cardiopulmonary examination shows no abnormalities. Serum creatinine is normal at 1.1 milligrams per deciliter. Normal range is 0.7 to 1.2. Urinalysis shows 1 plus protein and 3 to 4 RBCs per per field. Clearly, there shouldn't be any protein in the urine, so this is abnormal. 3 to 4 RBCs per field is actually considered negative, okay? And this you'll see this frequently on surgery forms as well. It need not be the case that you have 0 to 1. 3 to 4 is considered negative. It's generally over 10 that we consider it a positive finding. Questions asking the most appropriate next step in management. Now, in a patient who has high blood pressure, this question is an example of when you need to not overthink things. Okay, we're simply managing hypertension here, and we say, well, which medication are we going to use? Because we have two, hydrochlorothiazide and lisinopril, that could be potential answers here. Now, what I'm about to talk about is going to sound very specific, very pedantic, very nitpicky, but I promise you it's exceedingly high yield on family medicine forms. Okay, so if a patient has high blood pressure and has any protein in the urine, or has an elevated creatinine or renin, or has prediabetes or diabetes, or has atherosclerotic disease such as intermittent claudication, angina, carotid stenosis, if the patient has any of that, okay, we give an ACE inhibitor or an ARB because these agents decrease mortality in these patient groups. Now, you might say, well, if the patient doesn't have any of that, what do we do? The answer is hydrochlorothiazide or a dihydropyridine calcium channel blocker, such as nifedipine. Okay, if a patient is just on nifedipine, you say, well, that's like, you look at a patient's chart and you say, why are they randomly on nifedipine? Like, why that drug? Okay, it would mean, presumably, if the GP knows what he or she is doing, the patient doesn't have proteinuria, doesn't have elevated creatinine or renin, doesn't have prediabetes or diabetes, doesn't have atherosclerotic disease, okay? If the patient has any of those, he or she should be on an ACE inhibitor or an ARB, not hydrochlorothiazide or the dihydropyridine calcium channel blocker. Now, you might say, well, in patients who don't have any of those risk factors, why not just give an ACE inhibitor or an ARB anyway? It's because there's no proof that giving an ACE or an ARB to patients without these risk factors improves their mortality, okay? So for example, if your LDL cholesterol is not elevated, giving you a statin is not going to help you live to 120, okay? It doesn't further improve your mortality. So it's only ACE inhibitor and ARB are given to the patient groups as I described. Protein in the urine, elevated creatinine or renin, prediabetes, diabetes, or atherosclerotic disease such as intermittent claudication, angina, or carotid stenosis. These patients get an ACE or an ARB. Now, quickly discussing the echo and electrocardiography answers. This could be a very lengthy discussion. I made other clips on this stuff. If a patient has a TIA, stroke, or retinal artery occlusion, does not have elevated blood pressure, especially if the patient's older, we want to think about atrial fibrillation. We would do a simple ECG, electrocardiography. If they tell you in the last line that the ECG shows no abnormalities, you have to think about paroxysmal AFib. That's a 2CK detail. AFib is not often continuous. Patient will go home, have dinner, switch an atrial fibrillation for half an hour, pop out of it. So if the ECG is normal, but we suspect AFib, then we're going to do a Holter monitor, which is an ambulatory ECG monitor. If that picks up the AFib, then we're going to do an echo as the next best step to visualize the left atrial mural thrombus. A lot we can talk about, okay? Urine microscopy, wrong fucking answer. There's nothing specifically in the urine that we'd be looking for here. It's just a distractor. So you know the deal. I'm going to continue making more content. If you like my stuff, subscribe to my channel. And I appreciate your time. That's it.